All right, welcome to the Drug Action and Handling lecture for DH246 Pharmacology. So what is drug action and handling? So a drug is a biologically active substance that modifies cellular function in our body. We got to have a general understanding of how drugs take action, how they leave our body, how they're distributed, how they work within our body in order for us to make decisions regarding drug interactions. So, how a drug that we might use in the dental office can react with a drug that a patient is taking, or any side effects that might happen, which could be because of drug interactions or just because of the drugs that we are choosing to give when we're in the office. So we're going to go over a lot of kind of definitions here at first. So this first one is called the log dose effect curve. So when a drug enters the body and it exerts a biological effect on the system, right? So the drug is going to do its job. We're going to measure its response. So how well is the body responding to the drug that we're giving? The most basic way that we can do this is by just looking at a general curve of this action. So this top picture here is showing that. So when we plot the dose of something given, so we're increasing dose as we move to the right. If we measure the dose against the intensity of the response, the general thing that we're going to expect is that as we increase the dose, we are going to increase the effect. And it creates this curve. And this is just kind of the most basic way you can plot the effect of a drug and its response. However, if we take this curve and we replot it using the logarithm, which is just kind of if it doesn't make sense what this is, it's kind of like just a really fancy mathematical way of saying we're plotting really big numbers. So up here, this is again, a really basic way of plotting dose versus response. This bottom graph is using the logarithmic dose, which is we're called the log dose. And this is just a much more mathematical way of producing a graph showing much bigger numbers. And so what the basic thing that you need to understand is when we look at a log dose effect curve, as we increase the dose, the effect is first 0. So here's the dose on the bottom or the x-axis. When we look at the y-axis, this is the response, right? So we're looking at basically the same thing, dose versus response. But what happens is at first, when you have a dose, it's a really minimal dose, nothing is happening. And then at some point, as you increase the dose, a response begins to happen. And then as you increase the dose, the response is going to go up, it's going to go up. And then eventually, at some point, the response is going to plateau, right? So when you look at this diagonal line here, in the middle of that line is what they're calling it 50. So what that means is that's basically the midline of the effective dose. So this line of where we have a response happening to before it plateaus, this area here is going to be our therapeutic dose. So it's going to be a range. So from about, here where we start having a good response to about here before we plateau, this is our therapeutic range. This 50% point, that's where our real therapeutic range is. That's the midpoint of the therapeutic range. So again, this curve, this log dose effect curve, is plotting where our therapeutic dose is going to be. So it's another way of plotting the dose versus the response. So when we talk about potency, the potency is the amount of a drug needed to produce the effect. So potency is shown by the location of the drug's curve along the log dose axis. So if we look at this right here, this drug B over here is the less active drug. Drug A is the more active drug. Well, how do we know this? Well, because this bottom line, this x-axis, is still the dose, right? So over here, we have a really small dose, and drug A, it's boom, here we go. We start having a response really quickly at a small dose. So this is a more potent drug because we were able to get a quick response with a small dose. Whereas drug B, we were having to give a much larger dose before we started to see that response. So that's a less potent drug because we're requiring more of the drug in order to produce a response. So if we're plotting two drugs on the same graph, the drug that is to the right, that is going to be the less potent drug because we're going to need more of the drug in order to get that response. So now, let's see. So in this bottom picture, this is, they're trying to give you like more of a like real world example. So they're actually using real drug names and kind of which one would be higher potency and lower potency. So in this case, for meperidine, this one you would need about 100 milligrams of that drug in order to get the same response of 10 milligrams of morphine. So morphine is going to be a much higher potency drug in order to get the same response of pain relief. All right, so let's look at efficacy. So efficacy is the maximum intensity of effect or response that can be produced by a drug. So this efficacy just means the maximum response that we can get. So if you administer more of a drug, it's not going to necessarily increase its efficacy, but it can raise the probability of a side effect happening. So like when we look here, if you look at this little curve here, right, this is we are giving a very small dose, we're increasing our dose, an effect is happening, and then eventually it plateaus. When it plateaus, it means that we can no longer go any higher. We can keep giving more and more and more and increasing the dose, but the line is just going to keep plateauing. It's going to be flat, so it's not going to go up anymore. So it's reached its maximum efficaciousness or efficacy. So this drug here on the bottom, this is going to be a less effective drug, and this one's more effective, or its efficacy is going to be higher because you're getting a higher response. So if you were comparing these two drugs, let's say these two drugs are for pain relief, this one could reduce like mild pain because it's only going to have this, it's going to have this lower intensity of response, whereas this drug with the curve that goes higher, this is going to have a higher response. So like, let's say you compare just like for ease, like ibuprofen. Ibuprofen maybe is going to give you this response. It's going to relieve a headache, but maybe this drug is morphine. Morphine is going to relieve way more than a headache. So it's a more efficacious drug, right? So if we look back at the previous slide, these two drugs here, or if we look at morphine and meperidine, these two drugs have the same efficacy because you can see that they plateau at around the same rate, where just one is more potent than the other. So the difference between potency here versus efficacy. All right, so let's look at the therapeutic index, or the TI. So we briefly talked about this in our previous lecture. But the TI, or the therapeutic index, this is a ratio of the median lethal dose to the median effective dose. So we look at how much of a drug does it take to kill something versus how much of a drug does it take to actually create the effect that we want. So the therapeutic index is the median lethal dose divided by the median effective dose. So again, the lethal dose, the median lethal dose is the dose that causes death in 50% of test animals. And then the effective dose is the dose required to produce the desired effect in 50% of test animals. So when we look at these two things on a graph, here you can see the therapeutic effect is right here. And then when we keep increasing the dose, we can eventually get to the toxic or lethal dose. On this graph, they're calling it the toxic dose, but the toxic and lethal dose are the same thing. So again, we increase the dose, we go from therapeutic to lethal or toxic. So the greater the therapeutic index, so the greater the distance between these two curves, the safer the drug is. So drugs that have a lower therapeutic index, so if these two curves are close together, those types of drugs require really careful monitoring because you can very easily go from taking the right amount to taking the wrong amount. And those two doses are so close that it makes it a lot more likely that we're going to have some increased side effects or adverse effects from these drugs. If they're much further apart, then we know that it's safer because it's going to take a lot longer, a lot more dosing to get to that lethal or toxic dose. So, mechanisms of action of drugs. So, after drugs get to their site of action, then they elicit an effect. So, we take a drug, it has to travel to where it needs to go, and then it creates an effect. The pharmacological effect occurs because drugs change how the body works. They don't give it any new functions, they don't allow it to do something that it didn't already know how to do. They are either going to produce the same effect as an endogenous or a natural agent or natural thing in our body, or they're going to block the action of that thing. So these drugs amplify signals, they create flexible regulation, and they either slow things down or speed things up. So again, drugs do not give the body any new abilities or functions. They're just affecting what the body is already able to do. So how do they do this? Well, they attach to receptors. So in order for a drug to have its effect, it has to bind with a receptor site on a cell membrane. So drug receptors appear to consist of many larger molecules on the cell membrane or within the cell. More than one receptor type can be found at the site of action. Typically, a specific drug will bind with a specific receptor, much like a lock and key. So if we look at this receptor site here, receptor site A or drug A, this drug is shaped very similar to this site, correct? So it's like a lock and key. When we look here, it fits in perfectly. C and D here, these would indicate it's the same receptor site, right? Like that shape is the same, but the drug that's trying to attach is a different shape. It's either a square or a rectangle. It doesn't fit in the same way. It will still attach to the receptor, but it doesn't fit as well. So this specific drug knows that this is like its correct receptor. These drugs will still attach, but again, then they're not going to do the same thing. And we'll kind of get into that. But the key here is that the drugs, and they want to bind to specific receptors. Like that's their goal. That's how they're going to exert their actions. Different drugs can compete for the same receptor sites. Drugs with a stronger affinity for the receptor site bind to more sites. So like this drug fits better. So basically we could say that it has a better affinity for the receptor site. These drugs over here, they'll still bind, but they probably don't have maybe the same affinity because they're not really the right shape. More of a drug with a weaker affinity is needed to produce an effect. So we'll talk about that in another slide here, but big picture is that drugs have to bind with a receptor site in order to exert their effects. Drugs will typically bind with specific types of receptors, and they can compete for receptor sites. So when we look at drugs, we have agonists and antagonists. When a drug combines with a receptor site, it will alter the function of the organism or the human, and it either enhances or inhibits what it's trying to do. When we compare agonists and antagonists, the easiest way I like to think of it is an agonist. I think of go, agonist, like go, and I think like go, go, go. Like this drug is going to produce an effect. It's going to go, 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 produce an effect. Antagonist, I think of the word against, kind of looks kind of similar. And so antagonists go against the function. So antagonists are going to like prevent the function from happening. So again, an agonist, this is going to have an affinity for the receptor. So it wants to go to the receptor, it's going to combine with the receptor, and it's going to produce the effect. So if you look here, the agonist drug, it combines, it fits really well, and we are enhancing cellular activity. So whatever that drug is meant to do, once it attaches, it's going to produce that effect. And here we'll talk about antagonist drugs next slide, but just to look at this picture here. So the antagonist drug, it's still going to attach to this receptor, but you can see it doesn't fit quite as well. So what it's going to do is it's actually going to block cellular activity, because then if you have another thing that's coming in that wants to attach, this antagonist has blocked that receptor site. So this guy's just he can't attach. He's just going to bounce right off, right? So this antagonist drug is blocking the effect of something. So that's the difference between an agonist and an antagonist. Agonist is going to produce the effect, antagonist is going to block an effect. So looking a little closer at antagonists, there's multiple different types. So antagonists are going to counteract the action of an agonist, so they're going to block action from happening. A competitive antagonist means that it has an affinity for the receptor. It's going to combine with the receptor, but it's not going to produce an effect. So it's not going to do anything. It's simply blocking. It's going to cause a shift to the right in the dose response curve. And what that means, so if we look here, this yellow one is the competitive antagonist. This straight brown or brownish line, this is the agonist. So this is the drug that's exerting an effect, or it could be even just a natural agonist. So it's what's naturally occurring in our body. A competitive antagonist is going to shift that to the right. So what it's going to mean is that, let's say you have an agonist, you have a drug that's going to produce an effect, and this is its log dose effect curve right here. So it takes, X amount of drug, a low dose in order to produce its effect, right? This is the drug. If you have a competitive antagonist in the mix, this curve for the agonist is going to shift to the right. Because you have a competitive agonist competing for receptor sites of this agonist, it's going to move the curve this way. So it means that we're going to have a higher dose of our agonist drug in order to produce the same effect. Okay, so a competitive agonist is going to shift things to the right, meaning we need a higher dose of that original drug in order to exert the effect. Now we've got non-competitive antagonists. These bind to the receptor site that is different from the binding site of the agonist. So these ones reduce the maximal response of the agonist. So this is going to be seen here in this dotted brown line. So a non-competitive agonist, they're going to bind to different receptor sites, and they're going to reduce the overall effect of the drug. Okay, so they're just non-competitive agonists are going to reduce the maximum effect. So you had your agonist was up here, it was producing a high effect. Now that you have a non-competitive agonist in the mix, it's reducing the overall effect. Physiologic agonists, these have an affinity for different receptor sites than the agonist, and these are going to reduce the maximal response of the agonist by producing an opposite effect via different receptors. All right, now we're going to look at pharmacokinetics. So what are pharmacokinetics? So this is the study of how a drug enters the body, it circulates, it's changed, and then it leaves. So the four major steps involved in the pharmacokinetic process we call it ADME. So it's absorption, distribution, metabolism, and excretion, right? So we ingest the drug, we put the drug into our body, the body begins to absorb it, figures out where the drug needs to go, it distributes it throughout the body. Then once it's distributed and it does what it needs to do, sometimes it doesn't do what it needs to do, but it's distributed and then it's metabolized. So the drug is then broken down and then it's excreted or removed from the body. So pharmacokinetics is the study of this whole process of how the drug, when it enters, how it moves about, and then how it's excreted. And then ADME are those four major steps. So when a drug is in the body, it has to, in order to do what it needs to do, in order to go where it needs to go, it has to travel through body membranes or travel through barriers. So usually a drug needs to cross several different membranes or walls in order to reach the target in the body. These different barriers can be cell walls, blood vessel walls, and then even membranes within the cell. So the drug can get in the cell, but it needs to get to different areas of the cell to exert its effect. So it needs to travel through membranes within that cell. So lots of walls or barriers that a drug needs to travel through. Those membranes or those walls are made up of different fats, proteins, and sugars. So in general, fats, what are they doing? Fats make it hard for charged particles and certain molecules to pass through. So fats are kind of like, they're essentially creating a barrier. They're making it hard for things to travel through. Proteins act like gates, so they help specific substances to cross. And then sugars are attached to fats and proteins, and they provide various roles. So what's going to help a drug cross the membrane? So how does a drug, sometimes it's not very easy. So how do we help it? So drugs that can easily dissolve in fats are going to pass through those membranes more easily because membranes typically are made up of a lot of fats. Charged particles or ions have a harder time crossing than an uncharged molecule. So if we can get a molecule to be uncharged, it's going to travel through a bit easier. And then smaller, simpler molecules are going to slip through more easily than bigger, complex molecules. So when we look at different types of ways that molecules are going to move through these membranes, first we can look at passive transfer. So a lipid is a soluble substance. Soluble substances move across lipoprotein membranes by a passive transfer process called simple diffusion. So simple diffusion, an easy way to think of this is like if you had a glass of water and you dropped a few drops of food coloring in, the way that the food coloring distributes throughout the water is by simple diffusion or passive transfer. So when you drop the food coloring in, it diffuses. The food coloring moves to areas within the water where there is no food coloring, and it just kind of naturally diffuses or distributes itself throughout the water. This is kind of how simple diffusion works. So when you look at this side over here, this left side of this, you have a high concentration of something, whether it's D, which is the drug, the drug is over here, drug A. Through the high concentration of it, passive transfer means it's going to want to go through the membrane to this area of lower concentration. So that's simple diffusion. It's just going to kind of passively move through to an area with lower concentration. So this is directly proportional to the concentration gradient, or again, the difference between the drug across the membrane. So we've got a higher concentration on one side, a lower concentration on the other. So simple diffusion just means it wants to go to the area of lower concentration so that it basically equals out, so that we have an equal amount over here and an equal amount over here. So a very highly lipid-soluble compound attains a higher concentration at the membrane site and readily diffuses across the membrane into an area of lower concentration. So that is passive transfer. Specialized transport. Specialized transport means that, some substances, they've got to go across the membrane, but it's more complex. They're not just going to passively move through. Active transport, this is like pushing a boulder uphill. It means that we need energy to move the substances across from a low to high concentration. So we need something to help. So what we need is basically like a carrier. So these are going to use energy to transport substances across. So if we look over here at active transport, you can see that something is going to attach, and then on the other side, it's going to release. So this is our example of kind of active transport here. This process, active transport, this can be stopped. So again, this requires energy. So if we run out of energy or there's a metabolic inhibitor, then active transport can't work because we don't have the energy to make it happen. Facilitated diffusion. This is basically like going downhill. So this uses a natural flow to move substances from a high to low concentration, and it doesn't require extra energy. These are kind of like a specialized pathway or a tunnel. So again, we talked about on the last slide, passive transfer. This is just moving from basically a high concentration gradient to a low. Facilitated diffusion means that we're basically using like some sort of a tunnel. The tunnel is going to facilitate it. This is like a special pathway. Big things get in differently. So sometimes some scientists think that a process called pinocytosis helps large molecules to get inside. That's not super well understood, but anyway, we've got active transport that requires energy. Facilitated diffusion, that basically means that something is facilitating it, something is helping it to diffuse across, kind of like a tunnel or a passageway. Okay, absorption. Absorption is the process by which drug molecules are transferred from one site or the site of administration, so where we put it in, to the blood. And this requires passage through many membranes, obviously. Factors that influence the rate of absorption are going to be physiochemical factors, the site of absorption, which is determined by the route of administration. So site of absorption is going to be tied to where the drug enters the body. So if we take a drug orally, like a pill, site of absorption is going to be like our intestines. But if we give someone a shot, like a shot in the arm, site of absorption is going to be that tissue, right? And another factor that influences rate of absorption is going to be the drug's solubility. Okay, let's talk about the effect of ionization on a drug. So some drugs that are weak electrolytes can split into two forms. They can split into a charged and an uncharged form. Charged means that it's ionized. Uncharged means that it's unionized. An uncharged or an unionized form really likes fats, and it will slip through membranes easily because remember, membranes are typically very heavy in lipids, which are fats. So fats are going to slip through fats a lot better. So these uncharged drugs are going to go through a lot easier. Charged forms have a much harder time crossing these membranes. So this plays a big role in ionization, or whether or not a drug is ionized or unionized. It's going to mean how permeable or how likely it is to go through the membrane. So pH is really important here. So how acidic or basic the body part is, and then the strength of the drug itself, which is called as pKa. These both determine how much of each form, ionized and unionized, exist. So again, the acidity of the area and the strength of the drug, these determine how much ionized versus unionized are going to be occurring. So the more uncharged of a form there is, the easier it is for that drug to move around and get absorbed. So remember, uncharged or unionized, those are the same thing. Charged and ionized are the same thing. Unionized drugs are going to slip through more easily, and the ionized form is going to be less likely to go through. And again, remember, drugs, they can split into both forms. So that's what we're looking at. So when a drug splits, how it splits, how much ionized form versus unionized form is going to determine how likely it is to be able to move through those lipid-heavy membranes. All right, weak acids and weak bases. So this is kind of in your book, I feel this is a kind of a complicated concept. So the big idea here is that the form of a drug, ionized or unionized, it's going to determine how easily things pass through membranes in order to be absorbed. We just talked about that. The simple rule here is that a weak acid is going to absorb better in an acidic environment, and a weak base is going to absorb better in an alkaline or basic environment. So the big real-world example here is that infections create acidity in the body. So if you are going to be, for a real-world example, if you're going to use local anesthetics, which are a weak base, they're not going to work as well in an area of infection. So if a patient comes in and they've got like a big abscess on their tooth, a big infection that we're trying to, we're going to extract the tooth, or we're going to do a root canal on that area, we obviously need to anesthetize the patient. We know that because there's a bunch of infection in that area is now more acidic. There's more acidity than normal in that area. So we know that the local anesthetic, being a weak base as a drug, is not going to work as well because it's competing against that acidic environment. So that's kind of our big picture here when we talk about weak acids and weak bases. All right, oral absorption. So a lot of drugs, the majority of drugs we take are going to be pills, things that we absorb orally. Well, it could be pills, it could be liquids. But oral absorption is a really common way that we're going to take and absorb drugs. So dose form is an important factor affecting absorption when we administer things orally. And dose form just means, again, whether it's like a pill or a liquid, or, what form are we taking our dose in? Release of a drug in a tablet requires a lot of steps before it's actually absorbed. So when you take a pill or a tablet, there are different stages, the 4 Ds. So disruption. Disruption means that the pill, which has like a shell or coating on it, that has to be disrupted, right? So it has to be dissolved or somehow broken. We have to disrupt the shell. Then the contents that are inside of the pill have to disintegrate, right? So they have to break up. Then those particles need to be dispersed through the stomach and intestine, and then dissolution. So they need to be dissolved in the GI fluid before they can actually be absorbed. So a drug in solution skips these steps and has a quicker onset of action. So if a drug is in a solution, that basically means it's a liquid. So the drug is like dissolved in a solution already. So it's going to skip all these steps. It doesn't have a shell. It doesn't need to disintegrate. It doesn't need to have the particles dispersed because it's already basically, those steps are kind of done for it already. So a drug in solution is going to be absorbed a lot more easily than a drug that's in a pill form. It's going to have a quicker onset of action because it doesn't have to go through that process. When something is absorbed from an injection site, so we're going to inject, whether this is into our arm or our stomach or our mouth, we're injecting, right? So absorption from an injection site, this is going to depend on the solubility of the drug as well as the blood flow at the site. So drugs with a lower water solubility are absorbed really slowly after an intramuscular injection. This is also affected by the dosage form. So again, when we inject something, there are different forms of liquid that we can be injecting. So we just talked about drugs that are in a solution. That means that, it's a liquid and the drugs are like dispersed throughout that. Drugs that are in what's called a suspension, this means it's still a liquid, but the drugs are like suspended inside. Drugs in suspension are absorbed slower because the way that they are put in, when you think of suspension, it's kind of like, you think of like suspended animation. It's kind of like putting the drugs in so that they're going to last longer. They're going to like be absorbed from that suspension at a longer rate. So it means that they're going to be absorbed a lot slower. In a solution, it's like the drug is in the solution and it's readily available. So it's just going to, as soon as you inject it, it's free to be absorbed. It's not in this suspended form. And again, some drugs are formulated in a suspension in order to decrease their absorption rate because we want to prolong their action. So suspension versus solution. And the easiest way I like to think of it is, again, like I think of like suspended animation. So something's kind of like frozen for a period of time. So when a drug is in suspension, it just means that it's going to be absorbed a lot slower. And sometimes we do that for a specific reason because we want to prolong the action of that drug. So if we want something to be more quicker, faster acting, we would use it in a solution versus a suspension. All right, distribution. So all drugs occur in two forms in the blood. They're either bound to plasma proteins or they're free. So we have some that are bound and some that are just floating around free or unbound. So when a drug is bound, that's like a reservoir for the drug. So if it's bound, it's just like kind of saving the drug for later. The free drug is the form, there's a typo there. The free drug is the form that exerts the effect. So it means that it can pass across the membranes freely because it's not bound to anything. It's free to move across the membranes. The free drug can freely move, whereas the bound drug, because it's bound, it can't exert its effect because it's bound. It would have to become unbound in order to move across the membrane and do what it needs to do. So the proportion in each form, bound versus unbound, depends on the properties of the drug. So we're going to, formulate and create these drugs to be bound or unbound. We can kind of manipulate this, on a on the level of creation of the drug. So distribution, this is the passage of drugs into various bodily compartments, such as the plasma, the interstitial fluid, and the intracellular fluid. The manner in which the drug is distributed determines how rapidly it works, how long it's going to work, or the duration, and in some cases, whether or not it works at all. This is determined by the size of the organ, the blood flow to the organ, the solubility of the drug, the plasma protein binding capacity, and the presence of other barriers that might be in there. So again, how things are distributed, there's a lot of things that can affect it. Some of them we can control on the side of the drug and kind of how soluble it is, things like that. Some things we can't control, like patient factors. Like we can't control the blood flow to an organ, or the presence of some types of barriers in the patient's body. So lots of things are going to determine how well a drug is distributed. When distribution happens by plasma, so after the absorption at the site of administration, it's absorbed, a drug is distributed to its site of action by the blood plasma. So plasma is its main way of distribution. The biologic activity of a drug is related to the concentration of the free or unbound drug in the plasma. So again, the biological activity is like the effect, right? We want it to create a biological effect. We want it to have activity. So the amount of activity is related to the unbound drug, because the unbound drug is what's going to be able to pass across the membrane. So drugs that are bound, then they can be bound reversibly to plasma proteins. They're storage sites. So again, these are like the reservoirs, right? So bound means that they're reservoirs because they can reverse, they can become unbound, they can become biologically active, but when they're in a bound state, they're not. They're just a reservoir. So if one drug is very highly bound and another drug is very highly bound, it can displace the first drug from the plasma protein binding sites, which increases the effect of the first drug. So let's say you've got a drug in the body and it's really highly bound, right? So it's attached to all these little plasma proteins, right? Then you put another drug in the body that is also a highly bound drug. It might kick some of that first drug off the plasma proteins in order to attach. So then you're creating more unbound version of the first drug, which is going to increase its effect because now it's free to move across membranes and actually exert its effect. So how bound or unbound a drug is going to make a difference in how likely it is to exert an effect and how strong that effect is. Now let's talk a little bit about the blood-brain barrier. It's really difficult for things to cross the blood-brain barrier. So in order for a drug to penetrate the central nervous system, they have to cross that blood-brain barrier. This is going to be how likely this is. It's going to be related to its lipid solubility as well as its degree of ionization. And most drugs, like the way something's able to cross a membrane, is the same thing. It's lipid solubility and its degree of ionization. It's the same for the blood-brain barrier. The endothelium of the barrier, the blood-brain barrier, it contains a cell layer and a basement membrane. And these cells are welded together really, really tightly to prevent gaps and pores that would allow penetration of certain drugs. So the blood-brain barrier is just it is just much more tightly bound cells. So it's a lot harder for drugs to cross the blood-brain barrier. That's the big takeaway here. So drugs have to be, so not many drugs will cross this, and drugs have to be formulated in a specific way in order to make the cross. On the opposite side, the placenta is really easy to cross. So drugs crossing the placenta, this involves just simple diffusion based on the degree of lipid solubility. Most drugs will easily pass through the placenta. What that means is that drugs that are administered to the mother are going to easily pass to the fetus. So that's why when we have a pregnant woman, we want to be really, really conscious about what kinds of drugs are we giving her, because we know that they are most likely going to cross the placenta and be distributed to the fetus. And in a lot of cases, that can be not a good thing. All right. So now we're diving a little bit more into how drugs are circulated and absorbed and moved throughout the body. So enterohepatic circulation, let's talk about this. So drugs are typically absorbed in the intestines, and then they're distributed through the serum. They pass to the site of action. Then they go to the liver. The liver is where they're metabolized or broken down, and then they're excreted through the kidneys. So that's just the normal way that things happen, right? They're absorbed in the intestines, they travel around, they do an action, go to the liver, they're broken down, excreted in the kidneys. So when a drug undergoes enterohepatic circulation, the process will vary, but the steps are the same until they get to metabolization. So the metabolite, which is like, a drug gets to the liver, it's broken down into a metabolite. The metabolite is what's normally just eliminated through the kidneys. However, in this case, the metabolite is then reabsorbed. So it's secreted into the intestines via the bile. So here it is at the liver. The metabolite then is excreted through the bile, and it goes back into the GI tract or the intestines instead of being eliminated. So it's reabsorbed. So this process continues with every time a drug gets to the liver. If it is undergoing enterohepatic circulation, some of the drug will be eliminated. So some of the drug will be eliminated, but some of that metabolite is going to be excreted back into the intestine and reabsorbed. Then it's going to go back into the liver, where again, a little bit's going to be eliminated, but then some of it's going to be reabsorbed. And this passageway, this enterohepatic circulation, is going to prolong the effect of the drug. Again, it's going to get, the effect is going to be less at each passageway through this system, but it's not just all being eliminated. So again, some drugs are going to go through this enterohepatic circulation, some are not. It just means that it's going to prolong the effect because some of that drug is being excreted and reabsorbed back into the intestines. Redistribution, kind of similar. So this is movement of a drug from its site of action to a non-specific site of action. So the duration of action can be affected by this redistribution from one organ to another. And if redistribution occurs between a specific and non-specific site, then the drug's action will be terminated. So redistribution just means the drug is redistributing itself throughout the body, and this can affect its duration of action in the way that it moves from one area to another. All right, metabolism. So again, metabolism, this is also known as biotransformation, and it's taking the drug, changing it, or basically breaking it down so that it can be more easily excreted by the kidneys. Metabolism most commonly happens in the liver. This is where we can just assume most things are going to happen. The metabolite, which is the kind of broken down form of the drug, this is usually more polar or ionized. So when the drug breaks down, it becomes more ionized, which again makes this less lipid soluble. So this makes it easily to be excreted as opposed to being reabsorbed. Okay. So remember, the ionized form, less lipid soluble, so it's not going to want to be reabsorbed through those lipid membranes, so it's more easily excreted. Renal tubular reabsorption is reduced because renal tubular just means like the kidney tubules. So we're not going to be absorbing a lot of this metabolite in the kidneys because those tubes of the kidneys are going to favor lipid-soluble compounds. And again, when we metabolize things, they're becoming more ionized. So they're not going to travel through those lipid membranes as easily. And then those metabolites are also less likely to bind to plasma or tissue proteins or be stored in fat tissues. Again, because they are more ionized once they are metabolized. All right, some different types of metabolism. So we have active to inactive. This is the most common form of metabolism. This means that we have an active drug, it gets to the liver, and then it is transformed into an inactive compound, which is then excreted. We also have inactive to active. This means that you have an inactive drug that is then formed into an active compound in the liver, and then the inactive compound is termed a prodrug. Interference with the metabolism of this drug can delay its onset of action because it's harder for the active compound to be formed. This is not as common, but this is a form of metabolism. And then you have active to active. So this means that you have an active parent drug, that is then, when it's metabolized in the liver, it's actually metabolized into a second active compound, which is then converted into an inactive compound. So it's almost like there's an extra step here. So the total effect of this drug is going to be the parent drug, which is active, plus the effect of the active metabolite before it is converted into an inactive product. So this is going to mean that this drug is going to have more of an effect because it goes through two active stages as opposed to just an active to an inactive. All right, the first pass effect. So when a drug is given orally, it's absorbed in the intestinal walls, passes through the hepatic portal circulation, which is the liver. This can inactivate some drugs, and when this happens, it's called the first pass effect because it's the first pass through the liver. During the first pass, the drug is metabolized. The amount of the drug available to produce an effect is then lowered. And drugs with a high first pass effect rate have a larger oral to parenteral dose ratio. So what does this mean? So when you take a drug orally through your mouth, it goes into the GI tract. And so first pass means that some of it is going to be taken up into the liver, which is going to inactivate it. Some of it's still available, but some of it gets inactivated in the liver. So this is what happens orally. Let's say you take the same drug and you give this drug into the tissue. So you give an injection. That drug is not entering the GI tract. So it's not absorbed through the GI tract. So you don't have a first pass effect because it's not going to the liver right away. So none of it's being absorbed directly from the liver or from the intestine to the liver. It's being absorbed directly into the tissues. So that means that the dose that you give of that drug, if you give an injection, is going to be less than if you gave it orally. Because if you give it orally, you're going to give a higher dose because you're trying to compensate for this first pass effect or some of that drug being absorbed into the liver before it even has a chance to do its job. All right. Some different types of reactions. So phase 1 reactions. The body is going to change the structure of fat-loving drugs, which are many medications, to make them easier to get rid of. So again, when most drugs are going to be fat-loving because that means that they're going to be easier to pass through membranes, easier to absorb. Many drugs are made that way, right? But in order to excrete those drugs, we need to change them. We need to change them into non-fat loving drugs so they're more easy to get out of the body and not as easy to reabsorb. So the way we do this are going to be 3 main methods. So oxidation, reduction, and hydrolysis. These are all different chemical reactions that don't require a lot of energy in order to happen. So phase 1 reactions, how do these work? So oxidation reactions are the most common type of phase 1 reactions. We've got special liver enzymes called mixed function oxidases, and these are what do this work of oxidation. The level of these enzymes can go up or down depending on what other drugs or things from the environment that you're exposed to. And then this means that other drugs can make phase 1 reactions happen either faster or slower, impacting how the original drug works in your body. So big picture here, the more drugs that a patient is taking, so the longer their laundry list of medications is, the more likely that drugs are going to affect the way other drugs are working in the body. So if we're taking a bunch of drugs, these phase 1 reactions are either going to happen faster or slower because of how other things are reacting in the body. So then we have phase 2 reactions. So phase 2 reactions, with these, your body is adding special substances to drugs to make them easier to eliminate. So these substances include things like glucouronic acid, sulfuric acid, and other things. Most of the time, the body is using glucouronic acid, which is a natural substance. When this gets attached to the drug. This is called glucuronidation. So how does this work? So drugs have certain parts, like alcohols or acids, that act like hooks and hook onto this glucuronic acid. Special enzymes called transferases help to clip the glucuronic acid onto the hooks. And the result is that once attached, the drug becomes more water soluble and ready for your body to remove it. So phase 2 reactions involve the drugs having these little hooks. They hook on to these types of acids, usually glucuronic acid, and that makes them more water soluble, which is going to allow your body to excrete them a lot easier. All right, cytochrome P450 induction and inhibition. What's going on here? What does this mean? So the liver constantly works to break down medications, right? It is constantly trying to metabolize these things that are traveling through the body. So some things can speed up or slow down the metabolism process that's happening in the liver. So liver enzymes are one. You can think of these like the enzymes are like little machines that change the structure of drugs. This system of these liver enzymes doing this is called cytochrome P450 system. Speeding up, so certain drugs can make these enzymes work faster. This means that other medications you take can get broken down too quickly, which make them less effective. And then on the other side, some drugs can make the machines or the enzymes work slower. So this can make medications stay in your system longer and become stronger, potentially leading to side effects. So bottom line here, it's really important to be aware of how different drugs might interact with each other due to the liver enzymes. Okay, so we just talked about different ways and things that affect metabolism. Once the drug has been metabolized, it's then excreted. So the most common way that drugs are excreted is through the renal route. So this renal just refers to the kidneys, just means we're excreting it through the kidneys. So when you're looking at the renal route, there are 3 processes that really work together. So glomerular filtration, this is where small unbound drugs pass from the blood into the kidneys, filtering units, which are called glomeruli. Then we have active tubular secretion. So this is where special pumps in the kidneys are actively moving certain drugs from the blood into the urine. And then there's passive tubular diffusion, which means the acidity of the urine affects the drug's reabsorption. So more acidic or alkaline urine can trap certain drugs and prevent them from leaving the body. So it just depends on, again, how acidic or alkaline the urine is and what type of drug it is. So that will affect how much of it is able to leave the body. Now, there are other ways that drugs are excreted, and these are called extrarenal routes because, again, the most common form of elimination is the renal route. So the extrarenal routes are just the ways that are not the kidneys. So these include the lungs, where gases used in different forms of anesthesia and alcohol, these are excreted through simple diffusion. So that's why they're detectable on breath tests, like a breathalyzer, because this is how alcohol, once it's metabolized, is excreted. And again, as well as gases used in anesthesia. So that's through the lungs. Biliary excretion. So some drug metabolites from the liver are then excreted into the bile and then eliminated through feces. This is prolonging the drug's effects because you have enterohepatic circulation, which we discussed earlier. Saliva. So saliva can contain excreted drugs, which if there's drugs that are excreted into the saliva, so they're coming through the salivary glands into your mouth, typically that means you're going to swallow that saliva. So then that actually acts as an orally ingested drug. So it's kind of redistributing it that way. Because even though it's excreting into the saliva, it's not actually excreting it from the body per se. You're usually going to swallow that. And then drugs can be excreted in the gingival crevicular fluid. important for us to know in the dental field, because this can lead to high concentrations in the gingival crevices, which can be really beneficial in things like treating periodontal disease. So some drugs like tetracyclines will exhibit significant concentrations in gingival curvicular fluid, which is important to know because if we're trying to treat periodontal disease, these types of drugs that are going to be excreted into the gingival curvicular fluid might be beneficial in treating periodontal disease. Some minor elimination happens in breast milk as well as sweat, which does pose risks for nursing infants due to drug distribution. So if drugs are being excreted in breast milk, the baby is ingesting that breast milk, the baby could be ingesting portions of those drugs. All right, so now let's talk a little bit about pharmacokinetics. So remember, pharmacokinetics refers to ADME, which is absorption, distribution, metabolism, and excretion, which we've already talked about those a little bit, but we're going to dive into a little bit more here about some of these concepts. So half-life, what does half-life mean? So this is the amount of time that passes for a drug's concentration to fall to 50% of its original blood level. So the drug was in the blood at a certain amount, and then the half-life is when that drug is now at 50% of that original blood level. So it takes about 4 to 5 half-lives for a drug to be considered eliminated from the body completely. And even at that point, it still is about 3 to 6% in the blood of concentration, but we consider that to be eliminated because that's such a small percent. It's also going to take about 4 to 5 half-lives of repeated dosing for a drug's level to build up to a steady state in the body. And it can take several days for a drug with a long half-life to actually dissipate or be removed from the body or lower. So it's just going to vary on the different types of drugs. All right, now let's take a look at kinetics. So kinetics is the mathematical representation of the way that drugs are removed from the body. So first order kinetics, this is illustrated by this top graph, which you can see is a downward curve. So this means that this first order kinetics means that a drug is eliminated at a constant percentage per unit of time. First order kinetics is most common, and it means that elimination is equal to the drug plasma concentration. So you can see concentration very high here at the start, and over time, the drug is eliminated at a constant percentage. So we have this nice curve. So you can see in the beginning, the drug is going to drop, the amount of drug is going to be more concentrated. It's going to drop at a fast rate, and then as time goes on, it's kind of slow down, like the amount is going to slow down just a little bit. So it creates this curve. Zero order kinetics, which is this bottom here, means that the rate of metabolism is going to remain constant over time. And the reason that this occurs is because the enzymes that are metabolizing the drug become really saturated at a usual therapeutic dose. So again, first order kinetics is the usual way that drugs are removed. So this is like the usual curve that we're going to see. And then zero order kinetics is less likely, but it's because those enzymes are becoming saturated at a therapeutic dose. Lots of different factors that can alter a drug's effect. So let's review a couple of these. So patient adherence. So there's obviously whether a patient is taking their drugs or not is going to affect it. There's lots of things that can affect whether or not a patient is adhering to their medication regimen, right? Lots of things that'll affect that. And we'll talk about some of those right now. So like psychological factors. So the attitude of the person prescribing, whether that's the dentist or a doctor, and the dental staff, this can maximize the therapeutic result. So placebo effect. Placebo effect is very real, and it's a psychological factor. So if, as a hygienist, you're going to prescribe chlorhexidine to help with somebody's perio, if you are really talking it up like it's an amazing solution, the patient may be more likely to believe that it's going to work, and that can actually cause it to work, because that is the placebo effect. Whereas if you are kind of like, this might work, it might not work, that can also affect a patient. They might think, oh, the hygienist is not super confident in this drug or this treatment. I don't know that it's really likely to work. And so those can actually truly affect how well a drug works. Another factor to consider is tolerance. So with some drugs, if we are taking them for a period of time at a certain dose, we then have to increase the dose because our body is becoming tolerant to them. So we may need to increase to a larger dose. And obviously, if we're needing a larger dose, it's going to affect how the drug is acting. Pathologic state. So disease can affect a patient's response to a drug, even if the drug is not meant to treat that disease. So again, everything in our body is like working together. So whether we're taking multiple drugs and they're interacting with different receptor sites, or we've got some kind of a disease or pathologic state going on in our body that's affecting how things work and it's going to affect portions of that drug process that can affect how it's going to overall work and exert its effect. Time of administration. So this is a lot related to meals. So some drugs will react with certain foods. Some drugs need to be taken with a meal. So time of day that things are administered and what else we're taking at the same time, specifically foods. And then sedation. So when we talk about sedation and time of administration, it's like if we're going to give somebody a drug that causes sedation or has a side effect of sedation, we want to be giving it when we want the patient to be sedated or when they're most likely going to be asleep. And then we also have route of administration. So this is obviously going to affect the onset. So how quickly something reacts. So if we take something orally, like a pill, remember it's got to go through that whole process of disintegrating and being absorbed. Whereas if we give somebody a shot of something, it's going to have a quicker onset. It's going to be absorbed a lot more rapidly. And the routes of administration can also affect what the duration is. So how long the drugs will exert their effects. Other factors, so sex. So women can be more sensitive than men to some drugs, and then pregnancy can also alter effects of certain drugs. Genetic variations, so certain populations of people will have different responses to drugs. Drugs interact with other drugs, we know that. So depending on what types of drugs we're taking and how many, those can affect each other. Age and weight of the individual. So children obviously are going to be getting much smaller doses than adults. Older adults can respond differently to drugs than younger. So age and weight play a role. The environment. So substances in our environment, including smoking, pesticides, different solvents, those can affect how drugs work in our body because we are being exposed to those things. And then drugs can be altered by the patient-provider interaction. So again, the attitude of both the patient and the provider can alter how something works in the body, which is kind of crazy, but it is proven to be true. It's very true. All right, now let's dive in really quickly to routes of administration. I think this is our last topic in this PowerPoint. How are we going to administer drugs? What are the different routes? So orally, probably the most common. It's the simplest way. We've got tablets, capsules, and liquids. So we're taking these by mouth. So the advantage of taking something orally is that there's a really large absorbing area. The small intestine is huge, so it's a really large area to absorb the drug. It's got a slower onset of action because, again, it's got to break down in the body and it's got to travel to the intestines where it's absorbed. So it takes longer. Disadvantages, the stomach and intestinal lining can become irritated. This can cause nausea and vomiting. Some drugs can be inactivated by the acidity in the GI tract and then other enzymes that are in there. So again, we would hope that when we're prescribing drugs, we know if they're going to be inactivated by the GI tract and we don't give them that way. But that would alter, what route we're going to choose. Drug blood levels are less predictable when drugs are taken orally. because again, there's a lot of factors that influence how the drugs are broken down and then absorbed. So it's less predictable, what the dosing, I guess, should be per person. Food in the stomach, as well as pathology in the GI tract, can affect blood levels. Again, so if there's food in the stomach, that's going to absorb how things are absorbed and can interact with the drugs. And then also pathology in the GI tract. So how healthy is the gut? If the gut's not healthy, the problems in the gut can affect how well a drug is absorbed. All right, rectal route. So this includes suppositories, creams, enemas. Not a very popular option because patients aren't really into this, but we can use this if a patient is vomiting and unable to take something orally, or if they're unconscious and that means that they're not going to be able to take something orally. These can create both local as well as systemic effects, so they can create effects just locally at the site of administration, but then they can also be absorbed and travel throughout the body. Most drugs are actually poorly or irregularly absorbed in this way. So again, it's not something that we're using super often. It's used a lot in infants that aren't able to take things orally. But again, it doesn't have great patient acceptance, so not used super often. Intravenous route. So this intravenous route, this is going to be the most rapid drug response. It's almost immediate. Think about if you have ever been put under general anesthesia. They hook you up to the IV and then they ask you to count back from 100, and within like 3 seconds you're out. So it's got a very, very fast very fast onset. The absorption phase is bypassed because you're going directly into the bloodstream. So it's direct into the bloodstream. It's getting directly where it needs to go. There's no absorption phase. This is going to give us the most predictable response, again, because we're bypassing that hard stuff. We're just sticking it directly into the blood. This is ideal in emergencies when we need things to be, we need immediate onset. And then disadvantages here are phlebitis at the injection site. So that just means irritation at the injection site. Drug irretrievability. So once we inject it, it's in there. We can't get it out. And you'd think like, well, how do we get drugs out? Well, let's say, somebody takes something orally. Let's say someone overdoses and takes a whole bottle of pills. We can pump their stomach. We can induce vomiting, so we can retrieve the drugs sometimes, and obviously time plays a role in that. But when you give something intravenously, there's no getting it back. It's because it's so immediate. This also, allergy can be a disadvantage here. And then it also, because we're sticking it directly into the bloodstream, we're getting a really high plasma concentration, which hopefully we are going to, we don't have to worry about that too much because we're giving the correct dosage for the person. But again, it does create a very high plasma concentration, which could be a disadvantage. Intramuscular. So obviously we are injecting into a muscle. There is high blood flow through skeletal muscles. If you have a drug that can be irritating, this can be a better way to administer it. Injection of suspension provides a sustained effect in this area. And this is usually done into the deltoid or in the arm or into the gluteal. So this is how most vaccines are given, things like that, intramuscular. All right, subcutaneous. I felt like this was a good picture showing intramuscular, so going down into the muscle, subcutaneous here, intravenous, and then intradermal. So these are the three different kind of angles that you would do an injection in order to give these types into the different tissues. But subcutaneous, this is going to be injection of a solution or a suspension into the subcutaneous areolar tissue to gain access to systemic circulation. Insulin is most commonly administered this way. All right, intradermal. So this is where small amounts of drugs are injected into the epidermis. This can be used to provide local anesthesia in the area. In this area, a small bump is going to rise because the liquid is injected so close to the skin surface. Really good example of this is TB tests. We've all had to have a TB test done. And so when you go into your forearm, they inject a little bit of that solution, and they are using the intradermal route to do that. Intrathecal. So this is injection of solutions into the spinal subarachnoid space. This is used for spinal anesthesia as well as treatments of certain forms of meningitis. Intraperitoneal. This is placing fluid directly into the peritoneal cavity where exchange of substances can occur. This can be absorbed through the mesenteric veins. And this is also used for peritoneal dialysis during renal failure. So this is the intraperitoneal route. And then we've got inhalation. So this is where gaseous, microcrystalline, liquid, or powdered drugs are used. Inhalers are used to treat asthma. This is the most obvious, I think, example of the inhalation route, as well as nitrous oxide and oxygen. And this is popular for drug abuse because it's got a very quick onset of action in the way that it is absorbed. Topical. So topical is generally used for localized effects because many drugs do not penetrate the skin very easily. For dentistry, we have subgingival strips and gels that are dental specific, usually used for periodontal disease. So different things those are considered topical. We've got transdermal patches. So we've all seen different patches that you can use. So a lot of times people stick those on their arms or they'll be on their back. And that provides a continuous controlled release of a drug. And then we've got topical anesthesia, which we're obviously applying directly to mucous membranes. And then sublingual and buccal routes. So these are considered topical in the mouth by putting something under the tub sublingually or into the cheek buccally. Absorption occurs pretty rapidly this way because the tissue is very thin and there's a lot of blood vessels, especially sublingually. Drugs absorbed this way, they're very susceptible to degradation in the GI tract. Or drugs that are susceptible to degradation in the GI tract can be administered this way. So it's kind of like almost like doing it orally, but it's absorbed in the mouth as opposed to waiting until it gets to the GI tract. And then we have dosage forms. So dosage form is like how is the drug contained, right? So most common in dentistry, we're giving tablets and capsules that are given orally. Those are what we're prescribing. Liquid solutions are often prescribed for children because children are usually not, they haven't learned how to swallow a pill yet. For injection drugs, they can be either a solution or a suspension. And remember, a solution just means that it's already dissolved in the liquid, whereas a suspension means the drug is like suspended in it. And so it's going to create the drug's going to have a longer duration of action